have their own ideas and their own point of views, which they have developed out of their experience. We have two persons today who are going to talk on their experience. One of them is going to talk about an intraoperative ultrasound, without which he can still perform a very good surgery. The second person is one who has helped us any number of times. Many a times you do a nice PCNL and finally there is a bleeding and you don't know what to do. You go for an interventional radiologist. The second person is one kind of a guy who has really helped a lot of urologists with interventional radiology in post PCNL angioembolization. So let me start introducing the speakers to you. Dr. Mujeeburahiman, a robotic uro-oncology surgeon, is very good in other endourology procedures, open surgeries and laparoscopic surgeries, and over 15 years of experience. When I talked to him regarding this topic, he told me that he has his own experience and his own point of view in this procedure. He has done and improved himself as a very good robotic surgeon, even without an intraoperative ultrasound. And he wants to stress on that. He's a wonderful speaker, I guarantee. You are going to have beautiful 8 minutes from him. Can you go to the next speaker, please? The next speaker today in point of view is someone who has done multiple presentations as a radiologist at national and international levels. A member of Society of Neuroradiology, Interventional Radiology, and Pediatric Radiology. He is credited with the first endovascular coiling of intracranial aneurysm, endovascular coiling of Rasmussen aneurysm, and endovascular embolization of cortico-cavernous fistula in southern part of Tamil Nadu, and invited faculty in many CMEs all over the country. In Tamil, Periya means big. Periya Karpan is really a big Periya Karpan for most of us because he had been helpful for a lot of urologists in post-PCNL angioembolization. We welcome him as our guest. And the moderators for this session, we have three wonderful moderators, Dr. Ram Reddy, Dr. Ashok Pandit, and Dr. Janil Kumar. Now it is over to Dr. Janil Kumar, who is the on-session coordinator for this session.
I request Dr. Mujeeburahiman, who is a professor from Enopia Medical College, to speak on robotic partial nephrectomy without intraoperative ultrasound.
Robotic partial nephrectomy without intraoperative ultrasound. I stress upon without intraoperative ultrasound. Always in my presentations, I touch upon the history of partial nephrectomy. You all know that partial nephrectomy in 2021 has a definitive role in localized renal cell carcinoma. And as you scan the history of nephrectomies as well as the partial nephrectomy, in 1884 was the first partial nephrectomy open for a fibrolipoma. It took almost 90 to 100 years for partial nephrectomy, minimally invasive partial nephrectomy, that's in 1980s. Parallel to that, intraoperative ultrasound also came into the armamentarium, urological armamentarium. In 2021, you can see that the guideline stress upon partial nephrectomy has got a definitive role as far as the functional oncological control is concerned, functional outcome as well as the postoperative morbidity. Here you can see AU also strongly recommends partial nephrectomy, and NCCN guideline has gone little more elaborate, or they extended the indication even for a stage 3, for if it's technically feasible, partial nephrectomy can be performed. So that enumerating the steps of partial nephrectomy, I am concentrating my point of view on intraoperative ultrasound. That is the 6th of the 10 steps of defined partial nephrectomy steps. that my objective, I work in an institute where we have SI system, almost 500 and more urological procedures we have performed. And probably because of financial issues, we don't have an intraoperative ultra, but doesn't mean that I don't recommend intraoperative ultra. I strongly recommend for the special indications. So my objective of this presentation will be results of robotic partial nephrectomies in a tertiary referral care center using Da Vinci SI without intraoperative ultrasound, our point of view. So coming to the intraoperative ultrasound, it came in 1960s for the biliary surgeries, and later in 1980s were added to the armamentarium of urology, where in parallel it was a growth of minimally invasive surgery. Maximum partial nephrectomies have happened in the urology in 80s. And coming to the intraoperative ultrasound, it has got a real-time intraoperative ultrasound imaging. It has tumor localization. It has a definitive role in characterizing the border delineation, and renal perfusion during the clamping we can assess, and detection of multifocal diseases which were not previously seen in the CT or MRI. And now we have the contrast enhanced ultrasound, elastography, Doppler, all in. But the disadvantage, what I would like to highlight is the probe has to stay in contact with the tissue during the procedure, but it's not practical for a real-time guidance during the resection. And in vivo assessment of surgical margin may be slightly prolonged the warm ischemia time, the cause factor, which we will discuss during the moderate that session. So you see in the next slide, you can see that the diagnostic accuracy in centrally localized tumors, as per the literature, the CT and MRI which is performed before the procedure and before taking up the patient for the surgery, it's for the renal sinus extension and venous invasion. In other words, I'd like to stress upon intraoperative ultrasound has got a definitive role in managing the sinus tumors, the complex endophytic tumors. Intraoperative again 98% sensitivity. And coming to the positive surgical margins, when we were students, we have studied that definitive indications as well as relative indication for partial nephrectomy. But with the advent of robotic surgery, the technological advancement, as well as the inculcation of or inclusion of artificial intelligence, deep machine learning, as well as intraoperative imaging of the tumors, that with ultrasound, without ultrasound, and with ultrasound you can see. And the imperative indications up to the literature says that up to 18% of positive surgical margins are detected. And you can see that parallel there is a growth of intraoperative. There are other modalities like fluorescence, dual modality imaging, augmented reality, OCT, and ex vivo MRI. And augmented reality, again, whatever the newer innovations or inclusions are being at intraoperative imaging of the tumor for negative surgical margin and reduce the warm ischemia. This augmented reality, when you change, which the initial imaging is done in the supine position, and when you turn the patient to the flank position for a robotic partial nephrectomy, they have seen that 11 millimeter of displacement of a segmental vessel is seen. OCT, which has got is comparable to when you compare the gold standard for the histology, that is the frozen section, that is the histology. This is an 80 to 85% accuracy is seen in OCTs. Now, I'll come to our experience of 46 cases. I have taken out of 70 partials we did. I have, with the existing literature, I thought 46 cases were comparable with the existing literature. Number of cases, I have 46 cases, laterality left, more of right tumors, and exophytic 65%. And nephrometry score, this is what I have specifically the mild, moderate, and severe. As for the renal score, 51% were mild, moderate was 40%, and the severe was 9%. And my mean tumor size was 3.9, standard deviation of 0.6. There's 1.2. The maximum, the largest size was 5.1 centimeter. I have included in this. And the histology, you can see that in the slides. I don't want to spend too much time on this. I'll be comparing with this. And I would like to say this, my cognitive assessment is my method instead of intraoperative. You can see a dry field is a must for cognitive assessment of the tumor. We usually use the Scanlan Bulldog. Some of the cases I put 3 on the artery, vein is kept separate. And in 3 or 4 cases, we have taken the frozen section from the bed. But again, I'll say that as in the renal cell carcinoma, you know that frozen section has got a definitive disadvantage compared to the whole mount specimen. And most of the histopathology, uropathologists, they have the opinion that the frozen section doesn't have that much of a sensitivity or a predictive value in conclusively saying that this doesn't have, the bed doesn't have a tumor. Then another tumor I'll see that the partial nephrectomy for a central complex tumor. Here also I have not used the intraoperative ultrasound. This is a central tumor on the 3.5 centimeter central tumor was there. You can see on that left side there is a totally endophytic tumor that the longest diameter is 4.42 centimeters. And what I do as in this kind of cases, one sticky fat you can see, and a bulge and a thorough questioning or interrogation of the preoperative console anatomy with a recon picture, everything you have to do. This again we have done that whether you should have a mental picture like what you are going to operate upon. This again we have done a negative surgical margin, and this again we have taken a frozen section from the bed of the tumor. And coming to the conclusion of this comparison of the treatment outcomes of the partial nephrectomy T1B tumors with our results, you can see that the tumor size in the second graph, you can see that in our study, the tumor size was slightly less. As I said, this was 5.2 was the maximum size of the tumor, but the mean operative time is, previous slide, mean operative time was only, it is less compared because probably I'm not using an intraoperative ultrasound. And mean blood loss also is comparable. And I had one positive case, and it was in a moderate case. That was 1 out of 46 cases I had a positive surgical margin, but we have kept it for observation, and it was a recently done case. And coming to the conclusion of the intraoperative ultrasound, the best way evidence, as you can recommend, the moderators can recommend, but I can give you the evidence of my procedure or my point of view of robotic partial nephrectomy without intraoperative ultrasound from the literature meta-analysis. This is a review paper from European Association, European Urology. You can see that it remains to be proved whether intraoperative imaging has added value to support the negative surgical margins and improve tumor resection. To date, no randomized trials have been performed to compare partial nephrectomy with or without intraoperative imaging. And further, they are saying that intraoperative is indicated whether nephron-sparing surgery of tumors with a low complexity score, intraoperative imaging may have a limited relevance. However, currently, larger and complex tumors are increasingly being treated by nephron-sparing surgery. As these patients are especially at a risk of positive surgical margin, it's likely that intraoperative will be beneficial in this particular clinical setting. So, always that cognitive assessment is good at the conclusion. It is good for exophytic and mesophytic tumors, but intraoperative, I strongly recommend intraoperative in select cases where you suspect venous sinus involvement as well as venous involvement. And AI, artificial intelligence, cannot replace the wonders of the human brain and looking beyond the virtual. Thank you.
Dr. Mujeeb had a wonderful talk on the benefit of intraoperative ultrasound during partial nephrectomy. A lot of points I agree with Mujeeb, but a few of the points I want to highlight a few facts, probably which Mujeeb has missed in his talk. I am regularly using intraoperative ultrasound for almost all the partials, but I totally agree with few points Mujeeb has stressed. Should we have intraoperative ultrasound for all cases? I also feel that for all cases there is no benefit. There are particular scenario in which intraoperative ultrasound, I feel that without that I cannot proceed. What are the scenarios? One, when there is a thick adherent fat where I cannot understand where the tumor starts. In those scenarios, I have to mark the boundary with intraoperative ultrasound. Second, in a small tumor inside intraparenchymal, I have to mark the depth and the edge with the intraoperative ultrasound. Third scenario is if the margins are not very conspicuous, like it is just going into the kidney, without the extra renal component, probably in those cases also intraoperative ultrasound will help me to avoid loss of parenchymal fat. But putting everything together, if you ask me what is the most important thing without which I am very unhappy, is a proper CT, as Mujeeb has rightly told. We have to have a three-dimensional image of the tumor in our brain, or you have to have a visual picture with the modern technology to have a three-dimensional image of the tumor with the alignment of vessels underneath the parenchyma. All these things should be registered in our mind before we cut the parenchyma, so that in those cases, if you are doing it properly, probably we can avoid intraoperative ultrasound in good number of cases. Again, the most important factor I will stress is a proper CT. I routinely go for two-dimensional reconstruction of the tumor in arterial phase, in the coronal and axillary. And another thing I usually do is I usually just align the tumor position related to the renal vessels and its branches, so that if I am doing the intra-sinus dissection, I'll be able to identify from which area it is starting, which area it is ending. Even without an intraoperative ultrasound, in a lot of patients, I'll be able to proceed with partial nephrectomy. So this is the point we have to discuss, whether intraoperative ultrasound, which is a costly machine, which is required routinely, we may require in a few patients where it is very important. Lot of partial nephrectomy can be done without intraoperative ultrasound, but we cannot neglect the role of intraoperative ultrasound also. That is the exact point, Dr. Mujeeb has highlighted in the discussion. Thank you very much. Sir Ram, sir, your comment also.
Yeah, I agree with Dr. Mujeeburahiman. It definitely has some role, particularly when it is endophytic. It definitely has a role to spare maximum number of nephrons. But many of the surgeons, particularly open surgeries, they are doing without intraoperative ultrasound. So the same applies to even in robotic partial nephrectomy also. So only in special situations it is required, but many a times without the intraoperative ultrasound, you can do the job. Yes, sir.
Yeah. Can I talk to? In the open surgery, sir, what we have, the tactile sensation is there. We can feel the tumor. We can assess there, especially for the endophytic tumors, exophytic as well as mesophytic tumors. It's okay. This one, endophytic tumors in open surgeries, we can go with the tactile sensation coupled with our visual clues and the experience, and most of the things what they say negative surgical margin centers where they have max the volume of the surgery is done and the experience of the surgeon, that matters the most. It's one of the main determining factor for a negative surgical margin.
Unmute, sir.
Yeah, we are exceeding our time given. So shall we proceed with the next presentation?
Yes.